Hello, everyone, and welcome to today's training, Advancing the Wellbeing of Latino Families in DC using Community of Practice approach. For me, it's a pleasure to introduce our speakers. I am Dr. Cristina Miranda, the School Mental Health Lead of the National Hispanic and Latino Mental Health Technology Transfer Center. I want to remind everyone that the MHTTC network uses affirming, respectful, and recovery-oriented languages in all our activities. The presentation was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, SAMHSA. The authors declared no conflict of interest in doing this presentation. Our first speaker is Dr. Olga Acosta Price. She is the director of the Center for Health and Healthcare in Schools at the George Washington University Milken Institute School of Public Health, and she's an associate professor in the Department of Prevention and Community Health at the university. She is a clinical psychologist with postdoctoral training in school mental health. Dr. Acosta Price has dedicated herself to promoting prevention and early intervention programs that address the mental health needs of children and their families, and has developed, implemented, and evaluated programs promoting mental health and resilience conducted in schools and community settings. Our next speaker is Dr. Mariola Rosser. She is the project director at the Center for Health and Healthcare in Schools at the George Washington University Milken Institute School of Public Health. She has over 20 years of experience in social learning, system convening, and building communities of practice in education and school behavioral health. Currently, she coordinates the DC School Behavioral Health Community of Practice, focusing on improving provider and school readiness in implementing a multi-tier system of school-based mental health prevention and early intervention and treatment center. Also, we have Ima Iglesias. She is a senior clinical manager of Mary Center in Washington, D.C. She is a bilingual licensed clinical social worker with over 15 years of experience working with children, families, and adults in different multicultural settings. Please read the full bio of our speaker in our webpage. And now with Cindy for the full questions.
Hello, everyone. Thank you so much for joining us. We are so pleased to be invited to share with you some of what we've collectively been able to do in Washington, D.C. to really advance a comprehensive school behavioral health system. There we go. I just want to make sure that we are aware of what we hope to meet as learning objectives. We want to share a little bit about the unique challenges and opportunities with delivering behavioral health services in partnership with schools for Latino youth and families in DC, describe some of the essential elements and the value of community of practice approaches. We want to share with you a platform that you can utilize to create a shared learning space to advance any kind of initiative, in our case, advancing our behavioral health practice in our community, and to identify at least one engagement strategy that we've been able to adapt to support the well-being of Latino youth and families and to consider their unique needs. So those are the objectives for today. Again, I'm Olga Acosta Price. I'm the proud director of the Center for Health and Healthcare in Schools at George Washington University. I think the bio captured some of the essential pieces of my background that I think are germane to my role here. I will say that I'm a clinical psychologist by training and done my clinical work and my licensure in school mental health, and so have a deep appreciation for the role and the importance of bringing systems together and providers together to work collaboratively. Having done it as a provider, then as a supervisor, as an administrator, and now really trying to join others as thought leaders in the work. So I will turn it now to Mariola and Ima, my esteemed co-panelists, to just, if they want to say a few more words about their background. Mariola, did you want to, you're on mute. Would you like to say anything else about your background?
Thanks, Olga. Hi, everybody. I'm Mariola Rosser, and I work together with Olga at the Center for Health and Healthcare in Schools. I joined this center a couple years ago. Previously, I worked at the National Association of State Directors of Special Education, where I was connected to the federal grant focus on stakeholders' expertise. And as you learn from my bio, I am really interested in social learning and convening communities of practice that bring people together to address persistent problems of practice. I am originally from Poland. I've been trained as a therapist. I spent some time working with students with disabilities and community-based settings, and I am so happy to be here today. Thank you.
Hi, everyone. Hola a todos. I'm Inma Iglesias, and I'm a clinical social worker by training. And I'm currently working with the school-based mental health program at MediCenter, which is a community health clinic in a very Hispanic neighborhood in DC. I've been doing a school-based mental health for the last 7, almost 8 years. And I know the struggles. I know many of you that are listening want to get something out of this webinar in terms of tools and resources and ideas, and we hope that we can meet some of your needs.
Terrific. So we'll jump right in. So just to quickly say a little bit about our center, because it does frame how we approach the work. The Center for Health and Healthcare in Schools, which is our center at the university, is one that is very interested and really promotes our work through multi-sector collaboration, and that a real dedicated and intentional look at the policies, practices, and systems that really sustain long-term change and that bridge health and education so that we can promote learning for all students. So this public health approach, where we both appreciate and try to support individual behavior change, but at the same time also emphasizing the social and environmental conditions and factors that really also influence behaviors and outcomes. And so that'll be germane a little bit in, again, some of what we share with you. Again, although we hope and always try to think about the beneficiary of our work as individual children and their families, we also recognize that that children and individuals exist really within systems, and are there's an interaction between sort of individual skills and competencies and knowledge and other domains and other social influences, such as family and peers and neighborhood influences, and also schools. And so in addition to these more proximal environments, we also know that the broader social context and the broader social systems that are really brought to bear are also influential in determining how well development can occur, how to facilitate development of our population of young people. And so it's at that level of a system approach that we want to share. In particular, we're thinking about our level of intervention and what we hope to change to be at the level of practitioner and about practices that are embedded within our school environments. So I'm going to turn it for a few minutes to Inma, who's going to share a little bit about her organization, and then we'll turn to the rest of our presentation.
Yeah, so just so you know a little bit about the background for MediCenter, it started in 1988, and it was mainly built to support those Hispanic immigrants that arrived to DC. And here you can see some of the number of participants. Now, when I give these presentations, I want to make sure that people understand that while MediCenter started to serve the Hispanic community. It is now serving all communities, and we try to be as inclusive as possible. And we have staff members that speak several languages. So we're working very hard in making sure that people understand that all communities are included and everyone is served without, it doesn't matter if you speak Spanish or not. Within the school-based program, we are located at 19 schools. I was one of the first therapists hired with my program, and we expanded a big deal from 3 schools to now 19, I think. And you're going to hear about the impact that co-op has also had in the work that we do. But the school-based program right now is probably one of the one that has the biggest impact in terms of capacity and how many people we can serve. We have different health centers, 2 senior wellness centers, and we work with a public charter school. The mission for Mary Center is embracing all communities and providing high quality of care, education, and social services to build better futures. And this is the social change model that we try to emphasize in the work that we do, is pretty much treating health problems from a more comprehensive way of looking at things and rather just the symptoms. So from the moment that someone walks into our doors, we provide social services, we link them to other resources, and most of the time is also education, but we provide a home visitation. We have many services that you can check online, but the main model is just that we treat and support in all capacities and not just for the one reason that they might show up for. And here is some of the things that we're currently doing. Most of our services are now virtual, but anything that is dental and medical is in person. And so we have mental health, dental, health education, nutrition, chronic disease management, health homes, sexual health, and services also for the LGBTQ community. Some of the social services that we provide: case management, legal services, and you can read there. So we try to do as much as we can. And finally, some of the education programs for parents. There is a fatherhood program now that is very popular in the agency, trying to work with fathers as much as we can. English as a second language, digital literacy, parenting. There is also a big emphasis on early childhood education and preschooling. And we support youth with high school diploma, medical assistant training, and the Child Development Associate licensing through BRIA, which is our partner charter school.
Terrific. So before we move to the next slide, I do want to just check with our host if now's when we need to share the poll questions, or if that will just come later. I want to make sure I don't jump into the rest of the presentation too prematurely.
Yeah, I'm gonna show the poll questions now, and I'll read it for everybody just before we continue, and then you can go ahead. I'll let you know when the last one comes in.
Okay.
The first question says the majority of Latino families in DC are from El Salvador, and this is a true or false type of question. So 20% said true, 80% said false. Our next question says, DC public high school students have a lower rate of suicidal behavioral than their peers nationally. And then it's a true or false as well. %, said true, 72% said false. Our last question, in a community of practice, all members are leaders and learners. Once again, true or false? And for that last question, 81% said true and 19% said false. I'll leave you with Dr. Price now.
Thank you so much. So is the PowerPoint visible again for you all?
Yeah.
Yes, it is.
Yes. Okay, terrific. Thanks. Okay, so let's jump in. If I could ask our host just to remind me when, how much time we have when the webinar ends, so that I'm keeping track of time. Sorry that I forgot to ask you that before.
So don't worry. We're looking at 1 more hour, and I don't know if you want to leave room for questions, 10 or 15 minutes.
Yes. Yes, great. So that's what we'll try to do then. So let me tell you a little bit about the Latino population in Washington, D.C. So first, in terms of the general population, the 2018 census indicates that about 80,000 Latinos live in D.C., which is about 11% of the entire population of D.C. We have a little bit of a bigger representation within the school population. So of the over 90,000 public and public charter school students, almost 20% identify as either Latino or Hispanic. When we look at the countries of origin, the majority of families living in DC, a significant majority are from El Salvador. And when we also take a look at sort of the income distribution of families, we find that they are overly represented in the socioeconomic brackets that are sort of lower than of the average income across DC. So those are some of just the demographics that we wanted to make sure to share with you. Let me tell you a little bit about the child behavioral health needs and system in DC. First, I want to underscore that Washington, DC has actually invested for a long time and has historically been very involved in trying to think about bridging behavioral health services in partnership with public schools since about 1999, the year 2000, when the District of Columbia received its first Safe Schools, Healthy Students grant from the federal government and the Department of Health and Human Services. That allowed, and I was the proud founding director of that program when I was with the Department of Behavioral Health, and we entered into an initial partnership with 16 public charter schools to launch the DC school-based mental health program. What that allowed us to do is to place district employed clinicians in schools so that the provision of services were co-located with school-hired professionals, as model that many cities and localities around the country also use, as a way to supplement the care and the interventions that are provided in schools. That continued to grow steadily over the years as the interest of schools to be a part of that program and to have these supplemental services available. So it steadily grew to where we currently have 72 schools that are in partnership with that specific Department of Mental Health hosted program. In 2010, we had an unfortunate shooting that really resulted in the death of numerous young people, and the analysis and the outcome of that tragedy really pointed to some failures in our system that were encapsulated within a piece of legislation called the South Capitol Street Memorial Amendment Act of 2012. And one of the, some of the several provisions within that piece of legislation indicated that we really needed to take a much more intentional and thoughtful approach to how we make available and increase the access to behavioral health services in partnership with schools as one of the methods we could use to prevent the truancy that was and some of the conflict that had arisen previously leading to the mass shooting. As part of that, although it was passed in 2012, it was essentially an unfunded mandate, and no real dedicated funds were available to really expand what was already available through the DC school-based mental health program. But in 2016, with a lot of advocacy from our community members and from champions within our city council policymakers, there was the implementation of the South Capitol Act began in earnest, and a plan for how to actually expand those services to more than the schools that they were available in. The 2017, there was the adoption of a more comprehensive plan that was put forth to the leadership in DC to say this is how we intend as a community to implement the provisions within this act and the resources that we say as a community are necessary in order to have that happen with some level of fidelity and quality. So this task force was convened, the plan was accepted by the mayor, by city council, and by district agency leaders, which ultimately also led to the creation of an overarching body called the Coordinating Council for School Behavioral Health, which was convened for the first time in 2018. And this body is responsible for the oversight of the implementation of this plan. And about a year later, a community of practice was established with dedicated funds for a TA, a technical assistance provider, to really support the implementation of these new practices across all 244 schools, public schools that exist. And our center, at the Center for Health and Healthcare in Schools, was awarded that contract with the Department of Behavioral Health to be the facilitator of the COP. So let me just say what were some of the contexts within which we are working in DC. So we have many assets in our city. We definitely don't want to only point to the risks that are available and prominent, but that there also are a lot of strengths and assets across our communities. But child behavioral health remains a growing concern among our families, our educators, our providers, and other advocates. One startling statistic is that our high school youth in public schools in DC report attempting suicide at more than double the national average as reported in the YRBS, the Youth Risk Behavior Survey. And when we look at those statistics, we know that there are some groups that are actually much higher risk of suicidal thought and attempts that we need to keep in mind and pay particular attention to the ways that we need to engage and support them. Certainly our LGBTQ community of young people are at higher risk because of a number of exposures to increased bullying, increased isolation, and a number of other pathways that lead for them to be at a higher risk and ultimately to engage in more suicidal behavior. But also Hispanic females, which we know is also a national trend, and that according to our 2017 YRBS, high school females of Hispanic descent reported attempting suicide at a rate that was about 3.5 times higher than their white female classmates. So it certainly bore out in our own community these additional risks within our Latino community. The later YRBS that from 2019 had us also pay attention to the fact that in addition to anecdotal evidence that we were seeing suicidal behavior and ideation at much earlier ages and within earlier grades, leaving those in elementary school particularly to feel very unprepared for how they could support young people and feeling very surprised about the level of reporting of suicidal behavior. But that we see here that particularly also among our middle school population in DC, that middle school females remain at a notably higher risk than males for seriously thinking about killing themselves. And although the statistics, at least for middle school, don't show a great disparity or difference between Hispanic and Latina, Black females, but they, as communities of color, are indicating a higher risk than their white counterparts. In addition, we know that, again, among our high school students who indicate and endorse depressive symptomatology and suicidality, that is seen differentially across ward. And what we will know is in our city is that we are divided by 8 wards. And the disparities in health and educational outcomes are very much seen disproportionately in some wards versus others. And Ward 2 is a ward that has a much greater representation of Latino families than in other wards, although again, Latinos live across the city, but that is one where there's a higher concentration of Latino families and services in Ward 2. And so as we see here, the endorsement of having thoughts about committing suicide, planning, and attempting to commit suicide among high school youth is more prevalent in Ward 2 than in other wards. In addition, if we moved away from even suicidality and we looked at feelings of unsafety by race and ethnicity, that we see that among middle school and high school students, that we need to just continue to pay attention to how much individuals say that they miss school, they miss days of school because of feeling unsafe and feeling afraid of being beaten up at school one or more times. And again, you'll just see how that begins to play out in our own local community. So one of our responses to that, among many, is, as we mentioned earlier, our investment in not just having standalone programs in individual schools, but really thinking comprehensively across the entire system in the city to build a comprehensive school behavioral health system in DC. Part of the interest in doing that is we wanted to make sure that we were integrating what were both the historical public investments, but also the growing private investments from philanthropy and from other private sources that really needed to be integrated to enhance what we were doing across the city and the innovations we were trying to do. We wanted to build not only and leverage not only those resources, but also wanted to bridge and leverage the other complementary initiatives that were already happening across the city. There were really great work as it relates to community schools, to social emotional learning, to restorative justice, to being a trauma-informed school, but they were all happening in pockets that were not integrated or where we could cross-fertilize across initiative, and we wanted to also attend to that in our behavioral health system. We wanted to also not only think about important assets that we could build within individuals, young people and their families, and making sure that those competencies were able to be exhibited around better coping, around help seeking, around other ways to reduce symptomatology, but also to create conditions where all students were learning in health promoting environments. And what are the things we had to think about as it related to the importance of schools as an environment that's very powerful in the role of development of young people, and how our behavioral health system could positively impact the setting of the school setting. And then in addition, ensuring that we had a multi-tiered approach so that our behavioral health services were not only relegated to treatment services, but to early identification and to prevention in our system. The steps that we took to really try to realize this is that, again, we were very intentional at understanding and recognizing that the risk is not equitably experienced or felt across our city, and that there were particular wards and neighborhoods and schools that had more risk than others. It had populations that created greater demand for services, for support. We ranked all 244 schools, public schools in DC, on an estimate of a behavioral health need that included publicly available information to help us understand where those demands were. And we then also identified and incentivized 13 community-based organizations who were going to then be able to partner with schools, individual schools, in order to assign and co-locate licensed or license eligible behavioral health providers in schools to be integrated and work in partnership. Those schools and the CBOs could then enter into formal established partnerships, and together, ideally, assess the resource and assets and needs of those specific school communities, and develop a work plan that, again, would have a multi-tiered approach available, where they would think about a school-wide tier 1 approach, early identification and tier 2 approaches, and certainly enhancing the behavioral treatment and evidence-based approaches throughout the multi-tiered approach. In addition, we then, as we said, established a community of practice where we were focused and have been focused on the provider community and really supporting their competence and their ability and their confidence to implement what we know to be best practices in school behavioral health. What we've known across our city, because we've been so invested in school behavioral health for so long, is that we do have a lot of expertise and we do have a lot of knowledge about what those best practices are. What we recognize, particularly from speaking to our collaborators and our stakeholders, are the difficulties in actually applying those best practices in schools, and what those practice-based barriers are. And so I'm going to turn it now to Mariola, who is going to share with you then the approach that we've taken to really support the implementation, the effective implementation of best practices. And there we go.
Thank you, Olga. So community of practice approach was chosen by the coordinating council as an effective way to advance school behavioral health practices. And community of practice is known in many different areas, in education, in government, in nonprofit world. So it's a very popular way to create learning spaces for people that come together to change practice. And communities of practice were developed from social learning theory, and a person who coined this term is N.T.N. Wenger. And I had the privilege to work with N.T.N. for many years and really learn what it takes to build effective community of practice. So communities of practice are often defined as a group of people who share expertise and passion about the topic, and interact on an ongoing basis to further their learning. And members come together to solve problems, to share their insights, ideas, to share information, and they often co-create knowledge together and solve persistent problems of practice. And over time, these mutual interactions and relationships build up a shared body of knowledge and a sense of identity that it's focused on improving practice, but it's also focused on developing identity of collaborator. So Ima, if we can maybe go to the click on the community of practice elements. There are 3 elements that describe community of practice: domain, practice, and community. So domain in our case is the advancement of comprehensive school behavioral health and any issue within that domain. Practice is what we do. These are the resources that we develop together or share, experiences, stories, tools, and the knowledge that we build together to improve our practice. And the community are the people. So these are the relationships that we build. And sometimes relationships are undervalued, but in the community of practice, we really have a chance to embrace these relationships. And this is the glue, this is the energy that keeps us together and keeps us coming back. As people interact on the regular basis, they develop these relationships across schools, across systems, across agencies and partners in our city. And the relationships actually make this work better. And the DC School Behavioral Health Community of Practice was launched in September 2019. 2 months later, we came together to identify the issues that we really would like to address through our community. So we developed the DC School Behavioral Health shared vision that Ima just showed you. And so the DC School Behavioral Health Community of Practice is a diverse community of people who share expertise and passion for well-being of students, families, and school communities. And during our monthly meetings, the community comes together to generate ways to support school behavioral teams as they engage partners, collaborate to create safe and supportive school environment, and implement interdisciplinary practices that improve behavioral health and well-being. And each of the meetings is planned and hosted by practice group leaders who are committed to areas of expanding school behavioral health. So if we go to the next DCCOP structure, we will show you how we are operating and how we are connected. So currently we are working with 161 schools, and Olga described the work of the coordinating council and the path that led to the development of the community of practice. And we have a core team that advises the community of practice. And in that core team, we have members of our center and our partners from Department of Behavioral Health and Office of School Superintendent, and from the board of DCPS, and which is the District of Columbia Public Schools, and charter schools as well. And we meet monthly to learn about different patterns and trends that we need to pay attention. And we create the two-way learning between our core partners and the COP members. There are also other areas. We can go back for 1 second maybe to the structure, Ima. There are also other partners that we collaborate with and other initiatives that we align with. Like, for example, DBH and OSCE provide many trainings. So we connect people to these trainings, advertise them as they are related to our learning agenda. Also, Department of Behavioral Health have clinical specialists and project-aware coordinators. So we make sure that we connect to their work as well. So we are addressing different gaps that currently exist to make sure that we are on the same page and learning together. And as you can see, we come together once a month, and we also have 5 practice groups that are the smaller units within the community. And besides of these meetings, we also offer skill building chats, some trainings and tool creation and other social learning spaces. You probably cannot see very well all the practice groups here, but we'll show them a little later. But just to let you know, some of the issues that the community is focusing on is crisis response and intervention, family and youth engagement, positive school climate and social emotional learning implementation, school-based clinical supervision and leadership, and trauma-informed practices in schools. And if we can maybe go to value of the practice, these are some of the benefits and values that are known in general about the community of practice, and they really are universal. Community of practice brings people together from different schools, from different roles. So in our case, the most important partnership is the partnership between community-based organizations and school staff. As we know, these are often 2 different worlds, different training traditions, different experiences. So the community of practice provides a space for our members to get to know each other and to learn about each other's practice. So some other benefits and values are developing new skills, networking, belonging, sharing information, learning who to ask for help, so people can connect between the community of practice meetings, and also professional development. This is like we usually think about the professional development as a training that we have to attend, but really learning happens in different ways when we voluntarily participate in some spaces with colleagues based on our interest, and we learn through interactions. And specifically, our members share with us that, like the quote that you see, value of the COP, that they learn that community of practice is a secret place. It's really special to have the community of practice because it's a safe place to learn. And even if this is non-traditional way, but it's very impactful. And another person shared with us that sometimes the answer is not to shy away from asking people to consider putting more on their plates, but having them choose to do things that are energizing and build connections. So like sometimes the criticism that we get as we grow communities of practice and we engage people to participate or co-lead something and contribute, we often hear, oh, these people are so busy, they definitely will not participate. But there is some kind of magic that happens in community of practice, because when people are connected to the topic and they are interested and they are being asked, and we create opportunities for them to contribute and lead, be the leader and learner, we basically create the ownership. We support their agency. This becomes very impactful and meaningful, and it really changes people as they participate in these social learnings opportunities. So Ima, if you can maybe click on this line or below, it's very important as we're building community of practice to use a lot of engagement strategies. So as you are seeing Padlet and Lino here, we often do that during our interactions to generate engagement and get feedback. So this is the way how people share with us what was their biggest takeaway from our shared work. And we always incorporate these learnings into planning our meetings and next learning activities. So whatever we do, we focus on the content, but also we focus on the engagement. Olga or Ima, if you want to jump in and share anything, you're welcome to join.
Yeah, so this is a lot of info. It is a lot of info. We are giving you pretty much the theory, the background, and how things started. I will say, if you work at any school in the Washington DC area, members of wellness teams, support teams, people feel overwhelmed, and they complain of having too much work, too much need, and there is this sense of I cannot do enough. And that is a lot of burnout. So I don't know if anyone in the audience can relate to that feeling. So I will, if you are one of those people, if you can relate to this feeling, I will say, think about a potential to partner with a community agency in your city that can provide additional people to the school. So the reason why all of this started was because the schools were not able to meet the demand of the kids, the demand of the youth across ages. And so they started reaching out to community clinics like mine, saying, hey, can you send someone to support the work that we do? And the first thing that the school needs is providing the space. If there is no space to do services, the partnership won't work. And then through the expansion that we're talking about today, through the local money, DC was able to fund positions like mine. I started as a therapist 7 years ago and then became one of the clinical managers. But when I was a therapist, my position was funded also part with the billing that we do at MediCenter. So we bill for services, and then we have this local money supporting positions like mine. Then a co-op was created, the community of practice was created to really give us an opportunity for all of us to sit at the table, to be together, and then exchange ideas, exchange projects, and then new leaders emerged as well. So I will say, if you're working on your own today, within the school system, it is very challenging. I hear you, and it was one of our biggest challenges. Since now we created this huge platform across DC, working with other community agencies, with other clinicians, but also school staff, principals, administrators, the support team, then we've been able to identify needs across the city and then educate each other. So I'm going to tell you a little bit, and I don't know if you're able to see my screen. I hope you are. So I'm going to tell you how co-op has impacted the work that MediCenter does. And I will say not only MediCenter, but the other clinicians that are located within the schools. Co-op is open not only to therapists, but again, to anyone that is partnered, that anyone that is located in the school system that needs this type of support. So if you ask me, how does co-op help the Hispanic population? I will say, well, not directly. If you're looking for an answer today on the work that a community of practice does for the Latino population, I will say zero, because it's not tailored to the Hispanic population. However, co-op is the big platform, like the bigger picture. Then all of us come together once a month. We're over 100 people, and we choose a topic that was identified by many of you and me, like us that do the direct work day by day. Crisis response, how to do supervision, how to do parent engagement, how to work with teachers, how to support or how to provide trauma-informed classrooms, like it, you name it, and we're working on it. So because of the amount of need and the type of need, then all these groups started to develop. And like Mariola said, here is the list of groups. So from the big picture, we choose a topic, someone or a group of people present on it, and then the school counselors, social workers, physical therapists, anyone in the school system is able to ask questions and see and decide how they can take that info into their school sites. And then we split up by either specialties, topic of interest, expertise. And that is when, if you ask me, Inma, so how you just told me that you don't really help the Hispanic community. Well, hold on a minute, don't go yet, because what happens in these practice groups, the conversations are more intimate. So the one that I co-facilitate is the one on leadership and supervision. So once a month we meet, and we also talk about different topics that apply to all clinicians. One of them is multicultural supervision, reflective supervision, strengths-based supervision, trauma-informed supervision. But then I have other colleagues that join the rest of the groups, and we are able to tailor this info to the Hispanic population. So here I'm going to show you some of the things that have happened in the last year. I think the main one was COVID hit us very big. It was a big deal. From one day to another, everyone was sent home, and we were not ready to do virtual psychotherapy, virtual learning, homeschooling. So everyone went into a crisis mode. We had huge rates of mental health needs, and then teachers being like, how do I do this work? So I'm going to show you the first presentation that we did with COVID was this one on how do you do the work virtually? How do you do, I'm also a play therapist by training. How do you do play therapy online? So this is one of the resources that we shared. And I think you're going to have access to all these resources. But here is an example of how to do all this work. So the Padlet, the screen that you see, this is we also have one for co-op. So every time we meet, we put all these resources online, so that I don't have to be thinking yeah, I think in February or back in November, co-op talked about crisis response, or I think co-op talked about parent engagement. Where was that? All I have to do is go on the website and find the resources. So it makes my life as a provider way easier. What else we've done? We've talked about this community building circle, for example, that it can be customized to the Hispanic population by changing the type of questions and making it more culturally friendly or culture friendly. So just to tell you a little bit about the community building circle, which I think is a really nice initiative and way of creating community. It's pretty much everyone sits in a circle, and everyone takes a role. So for today, I'm going to go through a few resources so that you can consider either using this at your schools if you work in the school, or you can bring also this to your agencies or wherever wherever your work is. So everyone has a role. There is an open ceremony, and the idea is to address something, a challenge together, and it's a reflective process. Everyone participates, so you will be choosing a role who is going to be 1, 2, 3, 4, 5, 6, and then everyone reads all these slides that you see.
Yeah. Ima, if I can add to that.
Yes.
So the community building circle is the work that one of our partners in DC has developed, the restorative DC. So they actually really are expert, and we partner with them, and we're learning from them how to use community building circle for different purposes. So it's definitely a process that creates a safe space. that we can address different difficult and painful issues and improve relationships to resolve our differences. And the intent of the circle is to find resolutions that serve every member of the circle. And as Ima said, the beauty of that strategy is that every person has equal voice and every person has a role to play. So we've been using this strategy with youth, with families, with school staff, and in our community. So the intent here is that we are modeling an engagement strategy, and our members can customize it for their teams, for their schools, and they might tweak the content a little bit, change the question or change the quote. So the community building circle has this special design. It's really, they use quotes, maybe meditation, and these discussion questions to create this secret space for people to come together and work across the differences and resolve different conflicts that they might have.
Thank you, Mariola. Then there is also this other parent cafe, it's a word cafe. There is a special training to do this type of parent cafe. We've tailored it a little bit to the school where I'm placed. It's a bilingual school. The majority are Hispanics, and the way we've changed it to address the need of the community, and this was based on what the parents told us, was we created something similar to the formal parent cafe, but then added different components based on their needs. So when I present on a topic that they're asking about, I bring a case manager, and we spend 30 minutes talking about some of the popular resources right now in DC. For example, right now there is some funding through a program called DC Cares, and that provides a card with $1,000 for immigrant families that don't have documentation. So it's been helping them in paying the bills and buying food and surviving. Or there is a new resource based on rental help, for example. That's a big one in DC. Parents not being able to pay the rent since COVID because they lost their jobs. So these parent cafes may not look the same if my audience were just the white American parents. We are tailoring the cafes. One, they are in their native language, and two, we try to have a virtual background that they can relate to. Three, we use the language that they benefit from, even either it can be music from their countries, it can be pictures from their countries, so that people feel that connection. And then we build a place for them to build community by sharing the same trauma narrative. That is also an individual trauma narrative. But again, we make changes based on who these parents are. Another resource that
I jump in. So as Ima said, the parent cafe was, I guess it was developed by strong families, and they provide trainings how to facilitate these parent cafes. But in our community, we have number of trainers. And when we were focusing on this strategy, during our community of practice meeting, we invited some of the parents that were trainers in Parent Cafe to share their expertise with us. And that's another community of practice strategy to reach out to expertise that already exists and build on their expertise. And we have the practice group that focuses on parent engagement, and we have few parents in the core group of that practice group, and the plan is to expand. But as Ima said, we don't directly serve parents through the community of practice, but we build capacity of clinicians and school staff how to meaningfully engage families. So this Parents Cafe are run, facilitated in different schools. And it's also a safe, not judgmental space for parents to participate. And what describes the Parent Cafe, they have these protective factors, focus on resiliency, relationship building. So any topics that families want to discuss, this is the place where they can do that. And it's often, sometimes these groups are run by parents, sometimes by clinicians, but usually administrators don't participate in these spaces because of the content that is being shared. And there are some other forms of cafe that we tried. It's called World Cafe, that it's a free source and anybody can do it. And we provided some of the resources here in the Padlet if you are interested. So you don't have to be trained to do World Cafe, but it's really the same concept without the protective factors. And we adapted this strategy on online learning using Padlet, and it works very well when you want to engage people online in meaningful conversations.
Excellent, thank you. Here you will see other resources. For example, we've been helping people in creating their virtual classrooms, and I'm sure this is not new for you all. We had also a guest speaker from the Wendt Center here in Washington, D.C. They specialize in grief and loss, and they came to the community of practice 1 month as also we transitioned through COVID and people were experiencing this big amount of grief and loss. And that presentation was really, really good. So I think my point here is that if you can find partners, if you can work in these fields with other people, that's going to expand capacity, and it's probably going to impact the quality of the work that you do, because that's how it is impacting me as a provider and as a supervisor. I think one of the main lessons learned, or the biggest experience that I've had so far is one, feeling that I'm not on this alone, that yes, while I might feel isolated now in my house doing a school-based mental health, when I show up to these co-op meetings and the practice groups, there is a sense of community. People have the same or similar struggles. It gives me inspiration to continue this work, even though it is really tough and difficult, and we often lack resources. There is connection with peers, and then we exchange ideas. So here are some of those ideas that we would like to share with you. So for example, here on stress management and wellness, it was one of the presentations that I've done at my school in 2 languages, and also tailor a little bit to the Hispanic population, knowing that they cannot travel to their countries, that right now people are pretty much in quarantine, and that grief and loss and sadness that we carry. Like I said before, the play therapy room that has been big in doing therapy online. And before we end, because we would like to leave some.
If I could maybe also jump in for a second. I would like to highlight the nonprofit Wellness, which is one of our partners in DC, and they just focus on wellness for everybody in our community. They work with students and teachers and clinicians and families, and they have a number of resources available in Spanish, and they joined the teacher wellness work group that we co-facilitate, and they share their resources. So this is like this exchange process that it's available for community of practice, that one person develops something, the other person doesn't have to recreate the wheel. They can just borrow that resource and share with their networks. And like, for example, the wellness classrooms that Ima was highlighting, when you click on that, this is really like a PowerPoint of, I think, 8 classrooms that one of our clinicians developed. And as you click through some of them, like there is one that was developed for parents, and one in Spanish for parents also that is linked to self-care, to wellness. So this was all developed during COVID, when we are all struggling with self-care and wellness. And so wherever you click on this picture, it links you to the resource available in Spanish on parenting, on different topics that are of interest. So one person developed and the other people borrow this idea and link to their resources, and then we share. So you can just see how this collaboration works. And also there are a couple resources that the community developed together. So this is this co-creation of knowledge, like the self-care tips. We discuss how we are coping with COVID, and these are the strategies that people generated. So we put this in the infographic, and this can be shared by our members with families, with students, or based on that they can develop their own. Also, the Promoting Wellness Tips document has information how to promote wellness with families, all families. But of course, as Ima said, it can be translated and adapted for Latino families. Also, the teletherapy sessions, when we need to shift gears and focus on delivering therapy online, we developed tips for parents what to do, because there were issues that parents needed information on in order to support their kids to participate in these services. So this is like a circle, I think, learning, like a spiral. It's not one thing that we do. It's always, we always build on what we have done, and it's always to a learning. And there is one more thing that I would like to highlight for you, the authentic engagement, because all of this work is really driven by our support for engagement, authentic engagement. We want to create these authentic relationships, and we want to lead by convening. So there is an infographic that explains what leading by convening means, and below there is a document in Spanish that families develop, really how to engage families, how to promote and support leadership roles in families. So some of the highlights that we already discussed is that we believe that people are both leaders and learners. So we create opportunities in our community of practice to lead in place regardless of role, position, or title. And
so let me say before we, Mariola, I'll let you keep sort of sharing, and Inma, but I just want to, I don't see any questions in so far, but certainly I want to make sure that our hosts know that if there are any questions that folks put in the chat, or if we want to solicit them, we're happy to take our final few minutes to answer your questions. Also know that we have made available a handout of all the slides. So there's PowerPoint slides that really kind of encapsulate a lot of this conversation, and it has a link to this Padlet, which then you could go and explore and even add your resources, and you can download some of these resources, so that know that you can have that available. The link should be available in the PDF of the handouts. Any other, so can I, Christine, or are there any questions that maybe I'm not seeing that we should be mindful of, or should we just sort of wrap up?
Yeah, we do have questions regarding the COP. Mm-hmm. And it says that the program is great, and that their question is, how much time do mothers and fathers spend participating in this activity, and how do they measure the progress?
So how do we measure our progress as a community, and then how much time do caregivers, parents spend in the community of practice? So I'll start to answer that, and then I'll invite Inma and Mariola to say more. Remember, a community of practice is an approach that can be used in many different ways. And in our case, we intentionally used it, as you saw our vision statement, to really support all those who are passionate about comprehensive school behavioral health, and with an intentional aim of building knowledge and skills and opportunities to practice those skills for any clinician or school-based or school-linked provider, because we wanted to make sure that that's where we were seeing, so that we could measure the application of those practices in schools, knowing that if they get applied and they're more happening more often in schools, that we're going to see the kinds of outcomes, the better use of resources, the better teaming, the better collaboration, the better integration, the use of evidence-based practices that would drive down some of our unmet needs, and would make sure that we're identifying kids as early as possible who need that. And that's the kind of overall outcomes we're looking, that their wellness, their academic engagement, that families can indicate that they're feeling supported and they know where to get resources, and that's a role for as a part of this. But communities of practice can aim to do a number of different things. We are inclusive in our community. We want everyone. We want educators, administrators, families. But when we talk about specific content, it's often through the lens of what do we want to make sure all of our providers and those who need to apply this feel comfortable in, and we invite other unique perspectives to help us understand and make sure that we're doing that mindfully and in partnership. And so, to be transparent, we do have some families. We have, a lot of us are parents ourselves, but we don't often come in with our primary hat as caregivers. So we have a couple of people who do come in where their primary role and their unique perspective is as a caregiver or a parent, and they are very much helping to shape some of what we're doing. But we are trying to increase that involvement. But there are other spaces across the city, as Mariola had said. Sometimes it's not so much that we need to develop something new in our community of practice, it's that we need to link to something that's existing and that's effective, but we want to bring and share and have a cross-fertilization with that other. So we have other spaces where families come together for leadership skills, where families come together as advocates, where families and youth come together. And we want to be able to effectively link to that, as we're also creating a space where families feel they can also shape our specific approach. So I'll see what else, Inma and Mariola, you want to say in response to that question.
I'll say that parents don't come to these meetings. This is mainly for providers. So we expand knowledge and support each other, and then we take all those tools in our work with parents. But as we move forward, I think things are also changing, and we're hoping to include also more of the cultural piece, anti-racism, concepts like that. And maybe in the future, we might invite parents also to these platforms. But so far, it's the invite goes to providers across all schools.
Mariola, do you want to give the example of how we invited families to
Yes.
to help in one of our engagement strategies as an example that we're trying to build on?
The community of practice meetings are co-led by the practice group. So, like for example, in November, our November meeting last year focused on addressing implicit bias around family engagement. And we partner with family organizations in the city to plan that meeting, and they also co-facilitated the parent cafe that we use for that specific meeting. They also, we also collaborate with advisory group that is part of the coordinating council that focuses on family engagement to review different documents that we develop that are family friendly. And we also support the teams that participate in the community of practice to build their capacity around family engagement. So that's, I think, our impact. But our shared vision also talks about how we know that we're having an impact when so we say that when participating District of Columbia public schools and charter schools improve school climate and the social emotional well-being of students and families by demonstrating positive outcomes in such areas as youth engagement, social emotional learning, attendance, and academic performance. So we also pay attention to the engagement because in order for this work to be collaborative and really meaningful to all of us, the learning agenda cannot be developed just by Olga and I. That's why we have the big planning team. Like, for example, our next community of practice meeting that we having next week is focused on building strong crisis response teams. And we have 20 people from the community supporting this meeting, writing scenarios that represent real life situations, volunteering to facilitate, sharing resources, telling us what they need, what they don't need. So it's like truly driven by the community. And when we started on the beginning, the meetings were developed by core team or just few of us. And as we are growing the engagement and inviting more people to participate, we see that engagement. Because we really truly believe that people support what they create. So the value is actually in co-creating and engagement and participation, and then applying what we are learning in their practice.
So let me double check and see if, again, there are any additional questions, and certainly feel free to interrupt us. I want to make sure, Inma, if there were any other examples that you had that you wanted to point to. And I'll say before I kind of turn it to you that we're very intentional about we are implementing together an approach. So this isn't a program. This isn't a specific curriculum. It's an approach, and in that approach, we again were very intentional that we both wanted to make sure that we did some level setting and we made sure people understood what were known best practices in school behavioral health generally and what that meant, so that we were elevating everyone's competence in those areas, and that we were creating an opportunity for people to learn engagement strategies. So it's not enough to know content. You also have to know how to apply the content. And part of how we wanted people to learn to apply the content and to know how to make decisions about how to adapt those to their context is to feel confident in having various strategies for how to engage those in your community. And that means students, that means parents, that means your administrators, that means your educators in your context, because we wanted to empower the providers to be the ambassadors, to be the champions who together could work in their own individual context to then apply those principles and those best practices. And if it's particularly they're working with Latino families, if they're working with immigrant families, if they're working with whatever, however they have to adapt, that they now have the scaffolding available, those skills available to know where to adapt, how to check that it's actually meeting the needs of that particular community. Because then no matter what new issue, no matter what new stressor or whatever circumstance, people are going to have the capacity to be able to flexibly know how to adjust and how to sort of engage in a process. That's what we wanted to make sure we were doing, in addition to then sharing specific resources, specific tools but also to be comfortable in a process of inquiry and of co-developing and co-sharing with each other that we were creating. So Inma, any other examples you want to share?
No, I think you covered everything. Let's see if there are more questions.
Yeah, I would just add quickly that our April meeting is focused on preventing youth suicide, and we definitely will be reaching out to Latino families and organizations that work with Latino families to join the conversation, because as you remember from the data that Olga shared, the Latino girls are high-risk group. And we'll be working on solutions, how we can address this in DC schools.
Any other questions that have come up from our participants in the audience? We hope we gave you a sense of, as we said, our sort of a theoretical kind of underpinning and grounding for this work, how we're applying it in DC, how then, you know, it doesn't matter where you're starting, there's an applicable starting point, hopefully, if you were interested in your own community, and then that it's really a forum for collective action and collective work. It's a Padlet, the Lino, the community practice meetings, they represent spaces where they're repositories of kind of shared understanding, shared problem solving. And so that's what these represent, is those spaces that, and there's numerous ways to do that. And so we hope that you see some examples that could resonate, partners that you could imagine reaching out to help inform what this might look like. And then again, tailoring to what maybe the unique needs. And again, in our community, given that we know that we have families who have come and with particular commonalities maybe in some of the experiences, coming from war-torn countries, coming from places of conflict, having very harrowing journeys to come to DC, other things that we need to keep in mind and be sensitive to, but that there's also variability even within group, and knowing that we have to be flexible in how we adapt. But those are things that may be different in your own communities.
Thank you all for the answer. We do have a comment from the person that asked the question. It says, I appreciate your answers. I am running a similar program in the Northwest of Mexico, and I am faced with reporting results and at the same time ensuring good practices in favor of the participants. It's a nonprofit program by NGOs. Sorry.
Great. Well, we really appreciate knowing that you're doing some of this in the corner of your world, and I think again there's a lot of opportunities for us to learn across contexts, across cities, across jurisdictions around what people have found that they've learned can allow this to be successful, but it really does require an investment, of time, of buy-in, of willingness to share. But as Inma so I think well put it, in Mariola, what we have heard and what we feel is true is that that folks find value in that. And there's both personal value in feeling supported and feeling connected. There's professional value in that they are feeling they have then a forum for problem solving and to get new ideas and to share strategies. And so all of that, I think, is certainly worth the investments that have been made collectively.
And I just would like to maybe add one more thing. A person who asked how we measure impact, we are using the value creation framework that NTN Wenger developed specifically for communities of practice. And if you are interested to learn more, I can put my email in the chat box, and please contact us and we can share some of this information.
So I do thank everyone for staying with us, for your engagement. We hope that we gave you some practical ideas. We gave you some resources you could check out. We are happy to hear from you. If you have, our contact information is at the end of the handouts that we made available, so you can contact any of us. And thank you very much also to the National Center for this invitation to partner and collaborate with you.
Yeah, thank you all for a great presentation. I just wanted to make sure to mention, because I saw a couple of questions, Everybody's gonna receive a certificate of participation. It's gonna get through their email. So the email that you use to sign up, enter today's webinar should be the email you received this at. And I also share our link for the survey on the chat, because that's how we keep doing this incredible work and have awesome speakers as yourselves. So I just wanted to remind that to everybody and thank all our presenters for today for a great presentation. We do not have more questions. And I don't know if you guys want to say something else before we go. If not, I'll just end the webinar.
Yeah, I'm sorry that, at the end of the PowerPoint that I had up at one point, it does have that final slide with the code that could be used for SurveyMonkey to do the evaluation. So I'm not sure if you want that shown for a minute, or if folks will just get that separately, but just to know that it's there.
Yeah, they're gonna get it on their email as well, so it's okay. But thank you for that. Thanks.
No problem.